Hello, everybody, and welcome to this webinar on supporting the families of veterans, understanding the impact of veterans' mental health on their families, partners, and children. And let me start, first of all, by apologizing profusely for the late start. I'm afraid the gremlins have really got into the machinery tonight, and I'm even concerned that it might be COVID-19 has hit the internet because we've had no end of trouble. Unfortunately, tonight, we're going to have to go with audio only. You've got your slides. You should have the slides in front of you so you can read them, but you don't have the privilege of seeing our beautiful faces. And some would say that's probably a bonus. But anyway, hopefully it'll all go okay, and the content will be the same. So just listen to what people are saying, and I'm sure it will be worth its weight in gold. So firstly, can I welcome all of you who have joined us for the live activity tonight. We've had over 1,400 registrants, I think, which is an extraordinary number, and I think is a testament to just how important this subject is for us as clinicians. Welcome to all of you who are listening to us later on a recording, and of course a very warm welcome to our panelists who I will introduce in just a moment. Before we start, I'd like to acknowledge the traditional custodians of the lands across Australia upon which our panelists and our participants are located, and I'd like to pay our respects to their elders, past, present, and future. My name's Mark Creamer. I'm a clinical psychologist in private practice and also a professor in the Department of Psychiatry at the University of Melbourne. And I've had a very long interest in veteran and military mental health. And as a clinician, I am constantly struck by what must be the enormous impact on families when their loved one has a mental health problem. And so I am very pleased, very privileged to be able to chair this panel discussion tonight and to pick the brains of our expert panelists. So without further ado, let me introduce them. You all have their bios, and so I'll keep it very, very quick indeed. Our first panel member tonight is Joy Jenkins. She's joining us tonight from rural New South Wales. And Joy is here as a lived experience panelist. She's the daughter of a Vietnam veteran. She's the wife of a currently serving defense member. And I know that Joy is really passionate about mental health issues in the veteran and military communities. And so, and she has a particular interest in supporting families. So really, she is ideally placed to give us her unique perspective on the issues that we're going to be discussing tonight. So welcome, Joy, and thanks very much indeed for joining us.
Thank you, Mark.
I always like to start by asking people what they do to get away from work and to relax a little bit. And I understand that that you've become something of a builder's labourer as a way of getting out of work. Is that right?
I have. I've been helping my son build a huge deck on the back of our house, and it's almost at completion, so which will be very nice. My muscles will be very happy the day we put the last screw in the deck and hang up our tools for a little while.
I'm sure they will. And there's something very satisfying about that, isn't there? Doing a hard day's work and seeing something at the end. But I have to say, it's a slight pity that people don't have a picture because Joy looks about as far away from a builder's labourer as you can get. But anyway, I think it's a great thing. Well done, Joy. Thanks. Our next panelist is Karen Green. Karen is a mental health social worker with Open Arms. Open Arms, of course, was VVCS. Open Arms in North Queensland. Karen has specialist knowledge and expertise in military social work, and that interest has taken her all around the world. So we really are very privileged to have Karen with us tonight to share her expertise. Welcome, Karen. Thanks very much for joining us.
Thank you, Mark.
Carrying on with this idea of, what we do to relax, and I know that you're something of a traveller. Now, of course, who knows what's going to happen to travel with coronavirus. I'm sure it'll all be somewhat changed, but nevertheless, let's just forget about coronavirus for a minute and tell us about the trip that you at least had planned, which I think was half fun, half work.
Exactly right. I've got a couple of trips planned this year, hopefully, if all goes well. One is to Europe later in the year to celebrate my husband's 50th birthday and our 25th wedding anniversary. And then the other is to present at a conference on military social work with some colleagues around a book that we're working on entitled Military Social Work Practice Around the Globe. So fingers crossed that all works out very nicely for all involved.
I hope it does, Karen. I hope it does. That certainly sounds like a very interesting international collaboration, I must say. Anyway, good luck with that. Thank you, Karen. Our third panelist tonight is Brad Murphy. Brad is a general practitioner joining us tonight from Bundaberg in Queensland. He's had a fascinating career. Joined the Navy at 15. He then went on a few years later to train as an intensive care paramedic, and then eventually decided he wanted to be a doctor, and at the age of 35 started his training in medicine. He's now got a keen interest in veteran health, in Indigenous health, and in rural and remote healthcare. So again, ideally placed to talk to us tonight and to lend us his expertise. Welcome, Brad. Thanks very much for joining us.
Thanks, Mark. Great to be here.
So there's a whole wealth of interesting things I could pull out of your bio, but I'm not going to. I'm going to continue the travel theme. And again, for you, coronavirus aside, do you have any trips planned?
And I've got trips everywhere, and everything's been cancelled today. I've got to stay at work, but I'm hoping to head off to Greece in June, travelling with some friends and family, and they're meant to be doing a cruise around the Greek islands and a week relaxing in Greece itself. So God willing, we'll be there and have a couple of weeks of rest and relaxation.
I will certainly be keeping my fingers crossed for you, Brad, although I wouldn't be putting any money on it, to be honest.
I think I'll be at home.
Thank you, Brad. Our final panel member tonight is Atsumi Fukui. Atsumi is a consultant psychiatrist. She completed her medical training at the Universities of New South Wales and Sydney. She's a fellow of the Royal Australian New Zealand College of Psychiatrists, and among many other roles, she is a specialist consultant to the Australian Defence Force. So again, ideally placed to talk to us tonight. Welcome, Atsumi. Thanks for joining us.
Thank you, Mark.
I'm going to, if you'll forgive me, I'm going to ask you a slightly more serious question than I asked the others, because I was very interested to see from your bio that you have previously worked in senior management in the pharmaceutical industry. And I'm just wondering whether you think that might give you a different kind of perspective on your clinical work.
Yes, indeed. I mean, I think it was a great opportunity. I oversaw the medical aspects from drug development right through to marketing, and to really understand how the drugs that we prescribe, the journey that they've been on. I don't think it's something that, we're taught at medical school. And I guess I think a little bit more about things when I write a prescription for a patient, I think. And the importance of things like adverse event reporting and side effect monitoring and things like that. And it was a great opportunity because I also had the privilege of working with researchers and academics in the area of neuroscience. So I had a really great learning experience.
Sure. It's definitely another string to your bow, isn't it? That's yeah, I'm sure it's helpful. All right, well, thank you, Atsumi, and thank you to all our panel members. Let me just take a second to tell you about the webinar series. This is the 15th and final webinar in a series of webinars on veteran and military mental health that have been commissioned by DVA and conducted or run by MHPN. And we've covered a whole range of topics in that time, from PTSD through anger and substance use and so on. So if you didn't see them and you'd like to, they're all available from the Department of Veterans Affairs at Ease website or from the MHPN website, so check them out. But tonight's webinar, which is about family, the impact on families, will be covering some similar kind of ground to one that we first aired in about October 2017. So, the tech stuff. I'm assuming that this is still valid for you. Just very, very quickly, you've got a few buttons on your screen there. So you've got a purple button, which opens a chat box. If you want to post comments or chat to each other, you can do that. You've got a blue button to access the resources. And you can do that while we're talking, but I would also strongly encourage you to hang on, and MHPN will send you the link to those resources a week or two after we finished, and you can go through them all at your leisure then. I think there's a green button somewhere to help you refresh if your screen locks. There's a yellow button so that you can give us feedback from today, and that feedback is really very important, so please do it, but you can't do it until the end. So do not touch the red button until the very end. Okay, So tonight we're looking at the challenges that families and including partners and children face when their loved one is a serving member or a veteran who's got a mental health problem. And to help us do that, we're going to look at a case vignette, that of Jason. And you've all been sent that. I hope you've all read it, had a chance to read it. This is a fictional case, but hopefully there are a whole lot of things in there that ring a few bells for you among clients that you see. And tonight we're going to use Jason's story as a kind of springboard, a way of highlighting some of the key issues in this area. And each panelist will give us a short talk about their perspective on the case. And I should warn you that I've told them they've only got 4 minutes. So if they're sounding a bit stressed and rushed, it's my fault entirely. You can blame me. But after that, we'll open it up for questions and more general discussion. And then we hope that, I went too fast then. We hope that at the end of this, as a result of that discussion, you'll get a few things. That you'll be better able to recognize the impact of military service and transition on families, including partners and children. That you'll also be better able to describe what's available for them, the services and the resources that are available for families during the transition period, it says there, but I'd like to extend that out. And I think really we're talking not only about the transition period per se, but also later as they go on to life as a veteran. And as a result of both of those, we hope, of course, that you'll have increased confidence in supporting families of veterans who are coming out of the Defence Force. So, without further ado, let me hand over to our first panelist and ask Joy Jenkins to provide us with her very unique perspective as someone who's actually lived through these kinds of things. So, over to you, Joy.
Thank you, Mark. First of all, with the vignette from Melissa, I sort of looked at the wife perspective, and when your spouse or partner has been diagnosed with PTSD, anxiety, depression, nobody explains to you the emotion and the feeling that you're going to go through. So you're caring for somebody who is mentally unwell, but yet you're left wondering all these emotions that you're feeling. The person that you married has changed significantly, and there is no definite time of when this is going to be resolved. It's as an open-ended wound, so to speak. So for the wife's perspective, initially you're grieving the loss of your husband, the man that you've married, the man that you've come to know, and you're unsure of what that future is going to look like now. So throughout this healing process and the journey, you're feeling rather helpless. You're not sure what the family life is going to look like, whether there's going to be a turning point, and whether there's going to be positive outcomes. Nobody can give you definitive answers because you're on this journey of one day at a time. It's a confliction in the fact that you're on an emotional roller coaster, and particularly for Melissa, she tends to the needs of her husband, but she also has her children to look out for and herself. So all the self-care that spouses and partners do to try and mitigate the stressful circumstances that they're living at home, you also need to be available and watching signs, and depending on the age of the children, how much they can actually cope with, and helping them to get through this difficult time as well. But what comes with that is also the guilt. So how can you move on with your life or make choices for you and your family when you feel this obligation to somebody who is mentally unwell, but yet encapsulated in that diagnosis of being unwell is an unanswered question of, is this ever going to change? Is this ever going to get any better? Do I wait? Will there be a change tomorrow? Or what is going to happen? So the future is very uncertain. For children in this situation, and depending on how old they are, there's confusion. They see their father react in different ways that they're not familiar with. Unhealthy relationships start to evolve. You see children taking on roles that are beyond their years, or aligning with the parent who is the carer, and things get a little bit murky. It is not an easy situation for children, and I think even watching them and even knowing for myself, growing up in a home with a Vietnam veteran who had PTSD, it wasn't until I was removed from the home and was living on my own that I could then explore the difficulties that I had experienced and try and discern what is a normal life and what's abnormal under a PTSD household. And sometimes you need to step back to be able to get that reflection. But children of younger ages don't have the benefit of doing that. As the family work through this together, they become a solid unit and often will gather together, which leaves the partner feeling disconnected from the family. They feel like they're not fitting in. They've already got their own issues that they're dealing with, and they're not quite sure how to connect. But when they do connect, it's not how the children need the connection, depending on the age. So there's so many facets to that relationship and that family perspective that makes it very complex and difficult. Each day is difficult. You know, I have 4 children, so on any given day, we're not all going to be working in harmony together, and there's always going to be somebody who's dealing with an issue or trying to need something from their father that they're not getting or sustaining. So again, it's very, very challenging as a family unit to be working together in the time of having somebody with PTSD living with them, and the fact that it's ongoing. There is not an end in sight sometimes, and you just don't know how that's going to turn around. So with Melissa, you know, the future, making a decision about the course of their lives, it's not an easy decision. It's not something that any spouse or partner would take lightly. You have so many conflicting emotions, trying to make the best decision for all parties. And it's a time of being incredibly torn between what you knew, what is, and what is the future going to look like, and when do you make those hard decisions. Jason didn't ask for the injury. He didn't ask for this impact on his family. However, sometimes in the course of the illness, they can become very inward focused and not really understand or even realise the detrimental effects they're having on those that are around them, their loved ones who are only there trying to help them and support them. So, you know, complex journey for all the family. There is no easy answer. There's no quick fix. And Melissa's decision for her and her daughters would not have been a lightly made decision on any given day. And it's a painful situation for everybody concerned. And there's no winners. There's no winners in this scenario. So, it's a very challenging time.
Absolutely. And I would like to pick up on that point you made at the end there about the sort of stages that Melissa would have gone through in that process of leaving. But we are short of time, so I'm going to move on, if I could, to our next speaker. Before I do, can I just say a word to our participants? I think I forgot to say this at the beginning, in which case forgive me. And that is because we started 20 minutes late, we will finish 20 minutes late. So Eastern summertime, whatever we're on at the moment, we started at 7:35, so we'll finish at 8:55 tonight. And I hope that's okay. I hope it doesn't throw out your routines too much. Anyway, thanks again to Joy. That was fascinating, the whole wealth of stuff there that I want to pick up on. But now I'd like to move over to get a social work perspective and perhaps a perspective from an open arms position, and get Karen to talk about her reactions to Jason's story. Over to you, Karen.
Thank you, Mark. Yeah, from a social work and a systems perspective, I think, I guess the way that we might look at it is that the whole is greater than the sum of its parts, but it's also really important to look at what's happening in each of the parts of that family system and how each of those is relating to each other. So Jason has really struggled to adjust from having that really strong career soldier identity to now being a civilian, and he's also carried a whole range of health issues with that. Melissa, as Joy had mentioned, she had greater insight into Jason's health issue than he himself has. She has been proactive in trying to get support for herself and for him, but unfortunately he didn't take on board her advice, and that has resulted in the relationship breaking down completely. Those chronic issues and the social consequences as a result of his health issues have resulted in substance misuse issues and more recently that altercation with Ben. Overall, it seems like Isabella is able to compartmentalise issues. She's functioning relatively well within the family system, although there are a number of avoidant coping mechanisms that we can see. Melissa does feel guilty about not being able to get Jason the assistance and help that he needed, and as a consequence, there's a somewhat dysfunctional relationship that's developed between Sophie and Jason. So Sophie's taken on board a parenting sort of caring role. She's quite socially disconnected from her teenage peer group, and she has been engaging in really concerning deliberate self-harm behaviour as a coping strategy. So that's a number of challenges that are occurring there. In terms of the way that we could understand, or a framework around that for us to be able to understand and what is actually happening for the veteran family and partner, we can look at a veteran and family-centric model and really looking at the biopsychosocial elements of that. The context around that is looking at health, social supports, housing, finance, legal issues and safety for each and every member of that family. A couple of other really helpful points around that in understanding that might be to look at how those issues are impacting again, each individual person. But if we were to reframe questions instead of coming from a blame type perspective, to instead of asking questions like what's the matter with Jason or what's the matter with Melissa or with Sophie, to put it in more of a curious stance and asking, what matters to you, Jason, or what matters to you, Sophie? And by knowing what's important to each individual, we can support that person to make one positive change toward improved health, and that ripple effect is likely to have make a positive change, potentially interrupt those patterns of dysfunction, and then hopefully have a flow-on effect to a more positive interactions within that family system. The things that would really help, and certainly from within Open Arms, some of the things that we would be able to assist this family with would be counselling, definitely involvement in a comprehensive multidisciplinary team assessment, especially for Jason and Sophie. What we really want to do is work with them to achieve their goals of a better quality of mental health and well-being, and to help them understand that this is really achievable, it is possible. Really, risk assessment and safety planning is going to be essential, possibly case management, access to group programs, and then obviously self-care strategies, psychoeducation, and there's certainly an abundance of evidence-based resources through organisations like Phoenix, and certainly Open Arms. Our website has a whole bunch of really useful resources as well. That's where I'll end that, I think, Mark.
Thank you very much, Karen. That's extremely good timekeeping, if I might say so. Okay. Sorry, my phone has just done something stupid. Okay. Thank you very much indeed, Karen. And let's just fit in a very quick question, if I could. I guess this is a very, very complicated case, and I guess there's a whole range of places that we could intervene. I guess one of the challenges is where to start. Can I ask you what you would see as your first priority in this case?
Look, I think that probably the first priority for me would be assisting. Melissa is identifying Sophie as being the key area of concern for her, and understandably so. You know, the behaviours that Sophie is engaging in are really concerning, and that we really need to ensure that she has a really comprehensive physical and mental health assessment, and that would be assisting Melissa to connect with a GP for herself, but also for Sophie. It may be that we're supporting through a case management process of connecting her with a psychiatrist, perhaps down the track, but certainly ensuring social connectedness is a really important part for Sophie, but also for Melissa, and making sure that any kind of risks are mitigated by ensuring that everybody's really well informed about what it is that Sophie is doing. And the other thing I think that we have missed, or potentially in the vignette, is maybe we're unclear whether Jason's aware of Sophie's deliberate self-harm. So that would be really important to work in a family system to ensure that she's happy for him to know what is occurring as well, and then perhaps put some strategies in place around that.
Good. Okay, that's great. Thank you very much, Karen. There's a whole lot there that I'd like to pick up on when we move out into the broader discussion. Thanks again. Let's move on now and hear a GP perspective on Jason's case. And of course, this is important because very often the GP is the first and the primary point of contact, as I think really he was with Jason. So over to you, Brad.
Thanks, Mark, and thanks, Karen. I mean, a lot of really important points there. The first point for me in this is, who is your patient? And I suppose any one of these could be a patient. If you're in the big smoke, then you may well be looking after any one of these 5 people in their own right. And if you're in a rural perspective, you may well get to be honoured with looking after each and every one of them. And that can be a real challenge about, how you do that. Do you do that? I mean, if you're in a remote situation, you may not have the luxury of being able to refer people off to other providers. And certainly I've been in a situation just recently where this became quite challenging, where I was looking after a veteran and his wife, and there became a consequence of DVO and issues with police. And we were lucky enough to be able to, with open arms and other resources, to be able to handle that really well. But it's really tricky, and it's about how do you make that a situation where each of the parties are safe, but you also need to make sure that yourself and the staff of the practice are safe. And for us, we're on a little remote property outside of town, so we're not surrounded by other safety networks, and that's one of the things that works for us, but also is something that the staff need to be aware of. I mean, one of the really lovely things about being able to look after multiple people is that you get all of that collateral information, which means you sort of get the his, hers, and the truth, if you like. And, but certainly having because I have over 300 veterans on my books. We have a particular focus on veterans' health in our practice. But having the partners involved in that is really absolutely imperative, because we get a whole different perspective on what the veterans are going through. But, it's really important to make sure you don't then forget about the partner. And, I've had a lovely old lady crying recently in my office because we were able to access open arms for her. And for her, it was the first time that DVA had ever supposedly, apparently, had actually helped her. And that's really sad, because she had been an absolute stalwart in caring for her husband through a whole range of things that kept him out of institutions and the likes. And so it's really important that we don't forget the family on the way through. I've got another veteran I'm looking after with PTSD who's in and out of mental health institutions. And you can only imagine it's not dissimilar to the story of the vignette that we're going through tonight. He has 3 teenage children that we're supporting through. You can only imagine what it's like for them living in a family with PTSD, and mum's trying to keep things afloat, working and the likes. And, interestingly, you'd think they'd have a terrible perspective on the military, but the eldest is really keen to join the Navy, and we're working through aspects of how do we support her through that process. And I think that's the interesting thing here, is that as we think about this scenario, I mean, from my own perspective, joining the Navy at 15, I mean, Jason's had a militarisation perspective long before he got into the family journey that many people in civilian life do, and so his identity was well and truly enforced on that military perspective long before he sort of went down that road. And so if you look at the perspective for Jason and then the new fellow in Melissa's life, I mean, their perspective on the world is going to be different, and not necessarily right or wrong, but going to be very different. And as was mentioned in the last page of the vignette, they clearly see the world in very different ways. And like I say, not necessarily right or wrong, but very different ways on how that works through. And then that sort of feeds into how we're going to work through that. So, I mean, my own perspective through this and my team can be very different to another GP and their GP team who don't necessarily have military, background and experience. And I think the thing is, it's about not being afraid to ask for help. We're looking at the moment at setting up a special interest group within the RSCGP. DVA are extremely helpful in this perspective, and we're looking at ways that we can actually help to educate GPs, building upon ways within the military, and certainly it's much better now than it was when I was in. I was actually involved in doing medical discharges in the Navy, and I heard a DVA from my own perspective when I got out. Certainly, military guys now are being educated all the way through their military career about the role that DVA plays, particularly before they go on deployment. And so this is great, but they still don't necessarily understand the complexities of that. The 4 different legislations are really complex, and as each day goes by, as I learn more and more about veterans' health, I only realise how much more I don't know. Things change along the way. Understanding how D904 referrals work for veterans to get them involved, getting them the non-liability mental health care that they're all entitled to, and that's much better now with the Veterans Health Card and the likes coming in, so people are much more aware that they're entitled to that. The other day I sent a 82-year-old veteran to Open Arms, an 82-year-old man to Open Arms, not thinking that, this guy had a perspective of his father's, who was a veteran, who left them when he was a young fellow, but he had lots of concerns about that and various other things. But there was an opportunity to utilise the Open Arms process to help this guy. So I suppose understanding what's available and then sort of thinking laterally about how you might utilise it's great. And the other thing is I try, even though I can do a D904 referral for my veterans into psychology care, I'm trying desperately to recruit local psychologists into Open Arms and then refer the veteran through the Open Arms process, because 2 things happen. One is that the Open Arms psychologist and the team get paid more, and I think that's really great because then I can ask them to see more of my veterans without necessarily affecting their bottom line. But the other thing is that the process allows for documentation of the process and a journey. And if these guys are nomadic and they move around, and I say guys, non-gender specific, I mean, I've got male and female veterans that I care for, some of whom are husband and wife. But as they travel around, someone who goes on holiday or relocates to Darwin can then access that record. And it's a big challenge for my veterans is retelling the story over and over and over again. But because I become the common thread for them, it's been a really great opportunity because, you become a bit of a rock. And I find that after, sometimes months and years, veterans then start to engage in a different way. And I think you just have to go on a journey with them. But certainly being aware of the process and what Melissa and the girls have been through here, and the new partner, none of this is easy. And all of these people are good people just trying to survive this journey. And I think, understanding that, as Joy mentioned early on, when is this going to get better? And the sad reality is it may never. And, what stage do you sort of, take people on different pathways there? And so it can certainly be very challenging, as many of the audience would certainly appreciate. But I think it's about being aware of this, knowing how to refer, and just taking the time to try and get to know your local resources. I mean, we all have special interests in our own practices, and you might be surprised about opportunities that present along the way to preferentially refer to certain resources, which can certainly be really useful from my point of view. And developing that relationship as you start to, you have to be really careful because if you get a safety issue, and clearly there is here, you just have to be really careful because you have to make sure that everyone's safe in this process. And sometimes that challenges the relationship, particularly with if there's a violence issue or DVO. And just being honest on the way through is really imperative here. But maintaining people's safety is absolutely imperative.
Okay, thank you very much, Brad. I'm sorry to wind you up, but unfortunately time is going on. But thank you very much indeed, and there's a whole wealth of stuff again there that I'd love to pick up on, and we will pick up on in the discussion. But at this point, I would like to move on and hand over to our final panel member tonight to get a psychiatry perspective, not only about the family issues, but also about perhaps how we might help Jason. So over to you, Atsumi.
Yes, so I tended to focus on Jason because usually I would be seeing patients like Jason in my clinical practice. And I guess when you're trying to assess and manage someone in the military, it's important to remember some of the impact that the service has on these people. They don't tend to discuss work or trauma experiences with family, and even to clinicians. They may come complaining of symptoms, but unless you actually specifically ask about trauma experiences, they may not disclose what they've been through. And these may relate to incidents or accidents that may have happened whilst on duty, which have had physical and mental impact on them. But there are other things like morally compromising experiences that they've had. I see a lot of Navy personnel who've been on patrols for asylum seekers and refugees, for example. So it's very important to be aware of what they might have gone through psychologically. Obviously, we're aware that separation is a very common factor, and I recently saw a serving member of the Navy who said to me that of the 25 years that he's been in the Navy, he's actually been on deployments for a total of 20 years. And he's now trying to reestablish a connection with his 20-year-old daughter. And it's quite evident that, absence from home has had an impact on their relationship. So spouses and family members are often unaware of the veteran's distress. And they also have difficulty maintaining support networks due to frequent postings and isolation. And in this case, therefore, family support is very important because your work colleagues and peers may not be around when you need their support. So moving on to some of the psychosocial factors. Jason is obviously reluctant to seek help, and that relates to the culture of the military often, and not to sort of talk about emotional issues. He's certainly experienced loss of identity and career, having joined straight after school into the military, and the job defined him, his identity. And he's now lost not just his career, but, I guess his identity and purpose in life. Even if these veterans are well supported after they've transitioned out of the service, the effects of the traumatic stressors don't necessarily diminish after discharge. And like Jason, they've got to deal with ongoing physical issues. And so these are all important factors in managing these patients. And they experience feelings of anger, shame, guilt, blame, mistrust, and then often the consequence is withdrawal. So clinical consideration for someone like Jason, he presents a very typical picture of patients that I often see. They usually have injuries, and chronic pain is extremely common, comorbidity. Substance use is another complicating comorbidity. And when I read the vignette, I thought about, possible diagnoses of major depressive disorder, PTSD, alcohol use disorder, and one must always consider suicide risk in these sort of patients, which is much higher, obviously, in people who are transitioning out of the Defence Force or who've been discharged. So in terms of treatment options, I'm sure you've encountered all this in previous webinars, but it's important to take a biopsychosocial approach and work very closely with general practitioners and psychologists who are also involved in their management. I work very closely with psychologists, and obviously as a psychiatrist I oversee pharmacotherapy and make recommendations if I feel that people may need inpatient management, such as attending specialised PTSD programs, and also for those who have discharged, working with rehab consultants in terms of their supporting their recovery. And then also working with community-based groups. Often, a lot of them have attend self-initiated veteran support groups and so on, in addition to organisations like Open Arms. And just moving on to looking at Melissa and spouses and partners, I think that there's a lot of relational strain when they're married or partnered with people suffering from mental health issues, and they may have no idea of the veterans' issues until significant issues arise. And I have seen many cases where they have no idea until their partner needs to be admitted to hospital, for example. And my previous panel members have talked about the feelings that they go through. And it is important that they also look after their personal well-being and those of their children. And I believe that, if one can involve the partners in an assessment phase, it would be very helpful for both parties. And then focusing on the family, as has been mentioned, everyone is suffering, and I think that in this particular case, help for Sophie is paramount. I think I'd like to involve partners and carers when managing veterans and providing psychoeducation. And some do come with the veterans, some will come, if invited. And, I've found that obviously the prognosis is better if they have a supportive, caring partner. And it's about managing the disconnect that exists in the family. And support services for family members through working closely with GPs, psychologists, and other organisations. Safety is an important factor, not just for the veteran himself in terms of suicide risk, but also towards family members because of the issues of anger, potential violence, and the involvement of substance use that has been highlighted in this vignette. And I've encountered situations where there's been adverse outcomes of AVOs being taken out against the veteran and people with young families going to family law courts in terms of children's custody and so on. So these are sort of broader things that we need to keep in mind when managing the veteran in this sort of scenario.
Super. All right, thank you very much indeed, Atsumi. Again, a whole lot of stuff that I want to come back to there, and particularly your comment about engaging the partner in the process, which we will come back to. But I think now it's time to broaden it out and talk about things in a broader discussion kind of perspective. So I'd like to invite the panel members to just jump in and give their own perspective or add a different perspective or whatever at any point when they want to. And I would say actually at the outset that I have been extremely impressed by the number and the quality of the questions that have been sent in by our participants. And although we would love to go through each one in turn and answer them individually, unfortunately we don't have time to do that. I'm fairly confident that by the end, almost all the questions will have been answered in one form or another. But if we don't get to your particular question, please bear with us. But now let's broaden it out for a more general discussion. And I'm going to turn to you, Joy, first, if I could. And I'm wondering whether you think that whether sometimes it takes a while for partners to become aware of their loved one's problems, or do you think that it's obvious from the beginning that something's going wrong?
I think it varies from individual cases. For me, I noticed it as soon as my husband walked off the plane in Brisbane from being in Afghanistan for 6 months. So I really think it is the individual case upon case where if you're in tune with your husband or partner and to be able to pick up those finer things. So I don't think there's a broad answer that really covers all of that, unfortunately.
Mm. But I guess if people are working with the partner, it's something they should be aware of. I'm trying to think, that often that perhaps I've seen partners who tend to blame themselves for everything and don't consider for a minute that actually their loved one might be contributing to this in a pretty big way. So perhaps we need to be supporting them in that way. Yeah.
Yeah.
Okay, Brad, if I could turn to you, we are talking tonight mostly about the challenges of transition and then adjusting to life as a veteran. But there are presumably, in fact, obviously, challenges for families while the person is still serving. And I'm thinking particularly, for example, as one example, when someone comes back from a deployment, and Atsumi actually alluded to this with the person who was deployed for 20 out of 25 years. But when someone does come back from deployment, can it be difficult for them to adjust back into the family life? Brad?
Mark, I mean, the answer obviously is yes, but I don't think it's as simple as even when you come back from deployment. I deal with people that are 30, 40 years out of service and they still have trouble transitioning. Military people think different to civilians, and like I say, it's not right or wrong, but the thinking process and the way that we process our surroundings can be really different. And as Atsumi said, these guys often, when I say guys, men and women, they don't share this with their families. I mean, military and emergency service people are very similar here. My wife is just intensely upset that I am so the fun police about putting things on the stove. But it's because of my emergency service, background and the fire instances and what have you. And these things become part of your genetic code. So I think that's the issue we've got here. And how do we do that? And these guys are going to be wanting some feedback from their other veteran mates because it's not that their family don't understand. These guys sometimes don't want their family to understand, but they don't want their reality to be the perspective that their family come from. Just quickly, there's the girls in this case. I mean, I wonder how they see their dad. They grew up with their dad as a serving member, and they're going to be informed by social media and movies and the likes. And of course, now he's no longer in the military. He's got these injuries. He's a different guy. He's a drinker. It's really unfair. And so all these people are going through that transition.
Yeah, absolutely. Just as you were talking there, I was reminded of a video that I saw decades ago, shortly, not too long after I started working with veterans. It was made by one of the VVCS counsellors, as it was then, Open Arms Now. And I think it was called You're Not in the Forces Now. And it was about exactly that. It was about, the idea of having to leave behind some of the stuff that was so important to them for so much of their career. And
it's actually still available today, Mark.
Oh, is it? Oh, good. Well, I hope it's not too dated because I thought it was a really good message to get across. All right, thanks for that, Brad. Talking still about the impact on families, I am just interested, Karen, if I could bring you in. Do partners get any preparation for the process of transition? Is anybody there to help them prior to, during the process of transition out to the military?
Look, there's not anything like a formal training program as such, Mark, but there's certainly very significant changes that have occurred over the last, at least 5 years, and how people are able to and how partners are encouraged to attend things like the transition seminars, and that in itself has had a major overhaul, a reshape. Partners are strongly encouraged because we do know that the importance of people going through a really significant adjustment period and walking through that journey together with their loved one, and because we're also aware that people who are transitioning, like a military member transitioning from his or her role, depending on how long it's been as well, but they're taking their partner along that journey as well. So if for example, in Jason's case, he's been in the military for 20 plus years, as has his family members. So it's really important that people have an understanding and awareness, the families have an understanding and awareness of what that means, what's it going to be like to be in a civilian role. And we do, sometimes we'll hear of children in schools who still feel very connected with, similar to what you were saying, very, very connected with the military identity, and still feel like they should be able to go along to, military events and functions that are for families, even though they may have been out, their family or their dad or mum might have been out of the military for a really long period of time. It's a very strong cultural connection, and for many children and partners, that it can be really an important part of their identity, and that they're very proud of the achievement of their parent,
Absolutely.
and role that they play.
Yeah, but you talked there about doing this journey together, or working together on a process of transition. I'm going to bring Atsumi in, if I could, because I'd like to move on to the area of how we engage families in the process. And you talked, Atsumi, about how you'd like to try and involve the partners in at least assessment, if not perhaps in treatment or intervention. But I guess I'm wondering about, what if one or both partners refuse? Not everybody does want their partner involved. If they refuse, have you got any strategies to reach out and try and prevent the fractures occurring?
Oh, it's very difficult. I guess if they, for example, share a general practitioner or something, I could communicate to, involve a general practitioner to sort of, alert the general practitioner who may be able to engage the partner, for example. But I do encourage them to come, or recommend that maybe the partner can see someone independently as well. So somehow there is some help being offered in order for some sort of psychological connection to happen between them. But it is a very difficult area.
Yeah, quite. Joy, what about you? Do you think is there anything that partners can do to encourage their loved ones to get help, where the veteran themselves perhaps is not acknowledging problems or not interested in getting help? How do you think it's possible for partners to raise issues like that around mental health and encourage them to get help?
Yeah, I think so. I think if they are able to approach their partner and just diffuse the mental health umbrella and not try and diagnose them, but just say, how about we go and speak to a GP as first port of contact, and just open that discussion of the challenges that we are both facing. And I think when you do it as a combined unit, they're probably more amenable to going and having that first conversation without being labelled or thinking that they're the problem. But how about we go together and, I'm supporting you through this, and let's just go and have that first conversation. We might come out of there and there might be absolutely nothing wrong. But at least we've gone and we've seen the GP and checked all those boxes just to make sure, so that you can have a quality of life rather than struggling through something that may not need to be struggled through.
Quite. Okay. Good. I think it's good advice. And again, we perhaps need to be able to support and encourage partners who are doing that. Karen, just while we're still talking about engaging families, do you think that the ex-service organisations have a role to play in reaching out to families and supporting them? And I'm thinking about things like the PVA. Is that still going, the Partners of Veterans Association?
Yeah.
And Legacy and so on. Do you think, the ESOs have a role?
Look, absolutely, Mike. And I think that, all members of the veteran community, the veteran military and families, and ex-service organisations, everyone can play a really important role in understanding what services are available and sharing information about what's worked for an individual and what might be helpful for someone else. And I think, I really value the role of our lived experience peers and certainly, what Joy is bringing to this forum tonight as well. I think it's so important that it's not, clinical treatment isn't always going to be the go-to option for a veteran or a family member. So a soft entry point, whether that's through an ex-service organisation, a peer with a lived experience, or someone who is a family member who just knows someone who knows someone, or they can recommend a good GP, etc. That's the kind of stuff that multi-level, multi-sector is going to be helpful for getting people to the right, through the right door at the right time.
Sure, absolutely. That's a very important point, isn't it? About it's not a one-size-fits-all. It's going to be different things to different people. Brad, if I could bring you in, I suppose, prevention is better than cure. Do you think it's important to perhaps try and establish, particularly, I guess, for GPs, but to try and establish and maintain relationships with the veteran and their family when things are going well, and not necessarily wait until the wheels have fallen off and then try to engage them? Does that make sense?
Yeah, absolutely. We interestingly have a bit of an intake here as far as how we get our patients. We don't do walk-ins. It's a bit of an intake, and people actually come along often on recommendation from the experiences of others, and we pride ourselves in our practice about that relationship between the veteran and their family. So it's not about taking sides and the like. And interestingly, I've done a lot of work with veterans over the years about talking with them about their anniversary dates, because they're not always the ones that we would routinely think about with Anzac Day and Remembrance Day and the likes. There's all sorts of ones, and interestingly, they can be a real trigger to establishing that rapport and people sharing a little bit with you along the way, and it gives you a bit of a heads up about when you might want to put some extra support around them and around their family, and I think that's really great. And the thing is, if you do that, then it actually also invites the family to be comfortable to come and talk about the veteran experience. We notice that mum or dad's just starting to go a bit off colour, and they're saying different things, or they're behaving a little bit strangely, and it's a really great way because you've actually asked permission up front to engage in that process, and so people are more likely to give you that permission when things are well than obviously when they're in crisis.
Yeah, sure. Okay, let's move on a little bit then and talk about interventions, and sort of as a halfway point to there, I want to pick up something you raised, Brad, but I'm actually going to ask Katsumi about it. I was fascinated by your comment about the same provider seeing many people and the need sometimes to do that in rural areas to see many members of the family. But Katsumi, can I get you to comment generally on confidentiality with this population, whether it's a particular issue, not only perhaps, communicating among members of the family, but also perhaps back with the military? Are we allowed to talk to the health people on base, or what do you think? Any comments on?
Well, obviously, a referral comes from on-base medical practitioner, and I need to communicate back to them. But sometimes members do disclose certain personal things that they don't wish to be shared because their file, becomes electronic record, and basically it can be accessed by anyone who has the authority to access their medical records. So if I feel that there's something medically relevant, but that shouldn't be in a written document, I would call the referring medical officer to discuss it. And they're bound by medical confidentiality. So I keep it fairly broad in my correspondences.
But can I just interrupt there? I mean, you're saying you get the referral from the base or whatever, but sometimes the member may just turn up of their own accord and may not want the base to know. Does that put you in a different position?
Oh, I always get a referral, though. I have to get a referral from a medical practitioner. So you mean like if I...
Could just be Brad. It could just be a GP, couldn't it?
Oh, right. Yes, of course, that's very possible as well. Yeah. So in which case, obviously, it's not. There are no sort of conflicting, issues with the military.
Yeah. Yeah.
Because, you know, I need to be an advocate for the patient, obviously, and a lot of these veterans may have, you know, very negative views about, you know, the chain of command or the supervisors or the organization as a whole. So, yes, sometimes it is very, you know, important that, you know, you're not seen as, you know, taking the side of the military, that you're there for the patient.
Yeah, exactly. And that question someone asked, one of the presenters, I think it was Brad, said, who is the patient? Anyway, okay, good. Thank you for that. Let's stick on the idea of interventions and how we might help. Can I talk to you, Joy, as as our lived experience person? What do you think should be incorporated into, if you like, a recovery program? What may help mitigate some of the issues that Jason and his family are experiencing?
I think keeping the family involved in the recovery program, especially appointments with the professional, but it doesn't have to be every appointment, but it's sort of like a wellness check. So say, you know, if he's focusing on one particular relationship with a family member, maybe they could come along to an appointment once every 6 weeks, a couple of months. But that way the professional is getting a full exposure to what's really going on at home and the dynamics, and they can mediate between maybe some misconceptions or misunderstandings and help put them on the right track. So I think keeping the family involved, touching base, you know, observe a lot from body language and how they interact with family members. I think it's a wealth of information that the professional can actually glean from by inviting the family members into that meeting. And for the patient, they're not feeling like, well, you're coming along to every meeting, I'm still having my time, but it's a wellness check that you're just checking in on the family and seeing how things are going at home as well. And that's also an opportunity for the professional to explain to the family if they've got any questions or not understanding what's happening for, you know, the family member who's seeking help, then they can clarify at that meeting any questions they may have about his treatment or her treatment.
Yeah, I agree entirely, and I think you know, you've made that point very strongly, and Atsumi did as well. That I think all of you have really, and yet I do think it's something that as health professionals we're often not very good at. I don't remember ever being taught in my training that you should ask the partner to come in, and it's not something that many of us, I think, do think of automatically. So I think we should be much more aware of it. I'd say that I do now routinely, but it isn't something that I did for a long time. So yeah, okay, that's great. Thank you. Karen, I'm going to ask you a massive question that you're only allowed a teeny amount of time to answer. I want to ask about what's available. What has Open Arms got to offer partners and children? And I also want to, if you can, just say something about case management, because this is such a complex case that some kind of case management would be good. But can you just say quickly something about services for partners and children and then maybe case management?
Yeah, absolutely. Look, I think for partners and children, obviously we have counselling and group programs available through Open Arms. I think in the context of young children, what we would provide would be a family case. So where there could be some challenges if there are, say for example, in a case like this, if the kids are younger. What we want to ensure that we're doing is, as a community, we're helping to raise kids who feel emotionally secure, so that they feel accepted, they feel included. They're the foundations for success in school, in work, in life generally. And so the kind of things that we'd be wanting to do is to make sure that parents, including the veteran in this case, the kids were younger, like that they know the kind of strategies, the things that they need to be doing to make sure that the kids are growing up in a safe, emotionally secure kind of environment. So counselling would be one aspect. There's a bunch of other group programs or programs in the community. There's some great things like Kookaburra Kids activities that have camps and support activities. The other thing I think that is important, I mentioned peer support. Our model now within Open Arms includes the lived experience peers in all locations around Australia, and all, including regional centres. But in terms of case management, as you've just mentioned as well, like it is a very important component of what it would, in a very complex case like this one, that would be getting one of our clinical case managers to use his or her clinical judgment, do a really comprehensive assessment of the person's needs across all of those biopsychosocial domains, and then get the client to be engaging in collaborative treatment planning. So we would be, linking with every member of this panel this evening, and making sure that the goals that person comes up with are being monitored and evaluated toward their to progress their goals to where they would want to be at the end of their treatment program.
Sure. Okay. So there's a lot that you can offer, and my guess is that when people get sent the link to the resources, there'll be some stuff from Open Arms there. Would that be right?
Yes. Yeah.
Good.
And certainly our website is really comprehensive, Mark, as well.
Of course, the website too. Good. Okay, Brad, I want to ask a tricky issue about when the veteran becomes perhaps overly aggressive or violent, and I'm thinking at domestic violence as one definite possibility. And I'm wondering how important you think it is to set, I guess for partners really, to be setting limits and boundaries on the veteran's behaviour if it's getting out of hand, and perhaps even to protect the children. Is that an important thing for partners to do, and should we as health professionals be helping them to do that?
Yeah, Mark, I think it's absolutely imperative. I think the trick is, though, recognising this. I've certainly had cases. I've received veterans who are known to be violent, and some to be aggressive, anxious, and become very anxiety provoked. They're the easy ones to one degree, in that at least you can be forewarned and address these things. The thing is when it comes out of the blue and people aren't prepared for it, I suppose. But certainly we do it here, and I get permission, and I've had to call the police here for veterans, and I've managed to re-establish those relationships with patients. But a lot of our patients know right from the outset that we don't deliver bad behaviour, we won't accept it. And on the main, if people behave poorly, then we ask them to go elsewhere. I think it helps to establish this as a place of safety for them and for their family. And I think that's absolutely imperative moving forward.
Yeah, absolutely. Do you want just a very quick word on that, Joy? You don't have to.
I think a plan in place for the partner to know what is acceptable and unacceptable behaviour, and the veteran to acknowledge that. They can do a plan together, and it gives them a guideline that, okay, you've pushed the limits. This is the plan we've both agreed upon, and we can enact that plan for the safety not only of the veteran but for the family as well.
Sure. Okay, we could talk about interventions and management and so on until the cows come home, but unfortunately, time's running out. We've just got 2 minutes left, and given that we are talking to health providers out there, I would just like to spend the last 2 minutes talking about what we might do to improve sort of awareness and skills among providers. And Joy, I'm going to keep going with you, actually. Yep. Can you say just very, very quickly what you think the main differences are between people who were able to help you and those who weren't?
Okay.
Are there any key differences?
Yeah, I think a lot of it comes down to the professional themselves. We've had some really amazing professionals who embrace the family and really take on board us as a whole in the journey for recovery. And I think when that was happening, we saw the most success in recovery. When a professional is only focused on the veteran and maybe not having very much military understanding or background, we've found that things sort of plateau off. There's not a lot of movement, there's not a lot of improvement, and there's not a lot of inclusion. So I've had both sides of it, and I'd have to say, reflecting back, I really appreciated the professionals who were inclusive and really embraced us as a family to give a holistic approach to the care and the journey to wellness.
Okay, I wonder if I could ask the other three just to kind of follow on from that, and just very, very quickly, perhaps starting with you, Atsumi, very quickly, what you think is important for us to be doing in terms of training and developing health professionals to better work with veterans' families.
Yes, so I think it's increasing our awareness through programs like this webinar, and certainly the College of Psychiatrists now has a special interest group for veterans and military health, and we hold special seminars at various congresses and things like that. So I think there is an increasing. It's about education and understanding that I think working with military personnel is a special, sort of a subspecialty really, and to upskill our colleagues in that area.
I was thinking, Brad, while you were talking about the idea of the GP network, a network of GPs interested in veterans. I think it's a fantastic idea. But I'm also struck by the fact that probably many GPs don't see too many veterans, and they have many competing demands. And I'm wondering if there is a lot of interest, and also whether it's worth emphasizing similarities with other male-dominated groups, perhaps such as emergency services, that this is important for GPs to know. What do you think, Brad?
Yeah, look, I think it is, Mark, and you're absolutely right. I mean, one of the problems is, I've been very active around Indigenous health as well, and, it is about the number of patients that you have out of that target group and the immense amount of information you've got to process and get through in order to be able to give really good care. And one of the things that we proposed is maybe even setting up a helpline where, DVA are great with this sort of stuff, but you ring up and you get a public server and they give you a black and white answer to a grey problem. And I wonder whether, GPs and their teams having access to a helpline that would be through to a GP with an interest in this area to actually help people solve the problem. Because, I think if you've got seven veterans, if you had that number, that could actually, and you'd have trust then that, it might take me a day to get back to you, but I will. So I think we just have to be a bit clever about how we actually link these people up, particularly over the tyranny of distance.
Well, that's true. But I would put in a plug for the Centennial of Anzac Centre, which does have a professional support service, so people can ring. Should they talk to a GP? I'm not sure, but they can certainly talk to a specialist. Anyway, time is gone. Time is going very, very far. In fact, we're almost gone, really. So I'm sorry to rush you, but I think we should start to wind things up. And I would like to just give each of our panel members a few seconds to give us any take-home messages that they want, anything you'd like to leave participants with. So let's go in the order we started in. Joy, have you got any final comments you'd like to make to our participants?
I think just ask the question. Don't be afraid to ask the question, how is your relationship with your partner and family? And you might be surprised by the answer the veteran gives.
Yes, good advice. Karen, take over.
Look, I think the key thing to me is, whether it's an individual or a family member, plus really good concept of self-care, plus support from family or friends, plus professional care and community connectedness is going to equate to better health outcomes.
Yeah, good. Thank you, Brad. Any final comments from you?
I think just twofold very quickly. I think that each and every person that walks through your door is an individual, and if we take, we've got to get rid of stigma and the like. So every veteran, if you've seen one veteran, you've seen one veteran. And the other is to actually be aware of what your local resources are. And if we sort of talk amongst ourselves, we might be surprised about what we'll find in our own backyard.
Yes, good point. And Atsumi?
I think it's about being aware of not just the trauma within the veteran, but also the indirect effect it has on the family members, that, people can become, psychologically fatigued as a result of trying to support a veteran who has a mental health problem.
Yeah, Yes, good advice. Okay, thank you very much to all of you. I've just got a few quick closing comments, and I was very appropriate given Brad's comment about you'd be surprised at what's in your own backyard, that there are local networks set up by MHPN, and some of those are particularly veteran-oriented that allow multidisciplinary team or groups of people from different disciplines to get together, share resources, share ideas, do some peer supervision. So if you're stuck for any of those, if you'd like to be involved in one, do see the list there and get in touch. As I said, there's a whole lot of resources available, and MHPN will send you the link to those resources in the next week or so. So check them out and make sure that you find out what's there and so on. There's some great stuff there. There's also some great websites, of course, like At Ease and so on. Can I trouble you, please, to complete the feedback survey before you log out? It's really important for us to get some feel for how you found tonight. I must apologize profusely for the technical difficulties. I'm sorry about that, but hopefully it didn't detract too much from your experience of tonight. As I said, this is the last in the current series, and I would very much like to thank DVA for commissioning the webinars and for their commitment, really, to, I guess, to improving the lives of veterans and their families and to improving awareness among providers. I'd like to thank MHPN and Nikki Bisogni in particular for organising all these webinars. They may look smooth sometimes, but they take a lot of work. And also Redback in the background for doing the tech stuff. Tonight, thank you very much indeed to all our panelists, to Joy, to Karen, to Brad, and to Atsumi for what I thought was a great webinar. And finally, thank you very much to all of you, our participants, for joining us and for all your questions and engagement. You know, it really is your involvement that makes these webinars work so well. So thank you again to everybody, and good night.